are looking for the Circle Cleft Professional webinar, number 21, you are in the right place. Today we'll be talking with the key authors of the World Cleft Coalition Creating International Treatment Guidelines paper, which we're delighted to hear more about. And we'll just move quickly into the next screen, Niti. I'll introduce my colleague, Niti Daftari, who's the Manager for Global Initiatives for Transforming Faces and really helps to coordinate the Circle of Cleft Professionals. Please let us know what we should do today. How can we expect to interact with this content?
Thank you, Hugh. A few tips on using Zoom to make the most of this webinar experience. Please display your full name or type it out here on chat. It would help us to know who we are meeting with today and makes it far more easier to interact with each other. It would be helpful if you could please keep yourself on mute through the presentation to avoid any background noise. Zoom has these reaction buttons that Hugh just spoke about that you can use at the bottom of your screen to share what you're thinking or feeling while the presentation is on. So feel free to use it as much as you like. You can also use the Zoom chat to send across comments or questions while the presentation is on. After the panel discussion is done, we'll invite you to ask questions. You can either type out your questions using the chat box, or you can directly ask questions by unmuting yourself. Today, we will begin with a quick COCP update and 2020 overview, followed by the main presentation by W.C.C, which will be for about 30 minutes. This will be followed by questions and discussion for the remaining 20 to 25 minutes. Overall, this webinar will run for an hour. So what are the objectives of COCP? Our aim is to facilitate networking and collaboration amongst cleft professionals to communicate impact and the learning that's happening within cleft care, and that will in turn support the growth of local teams in implementing comprehensive cleft care. A quick snapshot of COCP in 2020. The COCP has grown tremendously in this past year. At the beginning of the year, we were at 145 members in fewer than 30 countries. We have now nearly tripled at over 400 members belonging to 12 plus specialties within cleft care who have joined us from 60 different countries across 6 continents. The COCP has a workspace on Slack where we have 14 different cleft care specialty channels such as surgery, speech therapy, social work. This one that you see here are conversations taking place on the COCP Slack nutrition channel. All COCP members receive an invite to be a member of our Slack channels, which gives you the opportunity to discuss and network with other CCC professionals. We now have 212 members in Slack, up from 95 at the beginning of the year. And of course, one of our key programs within the COCP, the webinars. We've had 21 webinars to date, 13 in 2020. With an average participation of 47 members in each webinar. We also have a COCP YouTube channel where you can access all of our previous webinars, including this one, which will be up on YouTube by tomorrow. We would love to invite more CCC professionals into our community. So if you know someone who might benefit from or would be interested in joining the COCP, please invite them to apply for membership through our website, www.cleftcircle.org. In September this year, we had our very first COCP conference, Solutions for CCC Responding to COVID. The conference was attended by over 140 participants from across 30 countries. We hosted 10 conference sessions, which included the opening and closing plenaries and 8 roundtables, all on a new socially interactive platform, Kiko Chat. After the conference, we shared a findings report that included a solutions-focused summary for each of the roundtables. This is available on our COCP website to download. We've also made available the recordings of all 10 conference sessions on YouTube through our COCP YouTube channel, so anyone can view it anytime. A shout out and thank you to the 10 international charity organizations and COCP supporters, all of who play an important role in supporting comprehensive cleft care in low and middle income countries. Over to you, Hugh, to introduce our panelists and topic for today.
Thanks, Niti. Well, delighted. It's a huge turnout this morning, this afternoon, or this evening, and Thank you for identifying yourself along the chat. It's lovely to see everyone's comments and to know where people are calling in from. Today, our last webinar of 2020, which has been quite busy. As you heard from Niti, we're delighted to have a really strong presentation about the idea of creating international treatment guidelines. And it's both the guidelines themselves, but you'll see in the description here, it's also the journey, a journey that started probably formally started right after the Cleft 2017 conference in Chennai. I see Suraj on the call, who was one of our hosts for those of us who were able to attend this meeting. But really, out of an NGO day that started at the very beginning of that conference, came this idea of working together. And I see my colleague Nan Hudson, one of the key organizers at that time, of pulling together. Is there a way for some of the key NGOs working on comprehensive cleft care to come together and articulate how we could work together? So I'm really delighted to introduce, you'll see the photos there. We have Gareth Davies from the European Cleft Organization, Dr. Ruben Ayala from Operation Smile, Dr. Serena Kassam from Global Smile Foundation, Erin Stieber, this SVP at Smile Train of Programs, Dr. Usama Hamdan, and Dr. Jamie Perry from the ACPA, and Dr. Usama Hamdan, as you'll hear, from the Global Smile Foundation. So we're delighted to have all of them here. We still, even though we have all that to cover, we are going to have some time, as usual, to discuss, to ask questions. So if you have those, feel free to put in comments or questions along the way as we go. We'll circle back. And then at the end, there will be time either for you to turn your video on or to type in some questions. And this really exciting panel will be able to address some of them, at least in the time that we have here. So without further ado, I pass it over to my colleague, Gareth from European Cleft Organization, who will kick off the presentation.
Okay, greetings everyone. I'm just waiting for the PowerPoint to load. We should be there in a moment. Really good to have this opportunity. As Hugh says, it really has been a journey, and I'm absolutely delighted to see that everyone who's been part of that journey is on this call today, which is wonderful. So we'll give you a very brief overview, and then I think the important part for us is to understand how people view our piece of work and how people can contribute. So who are we? We're a mixture of NGOs working in cleft care, American Cleft Palate Association, Smile Train, European Cleft Organization, Operation Smile, Transforming Faces, and Global Smile Foundation. We're an informal alliance. You can put faces and names together here. We have all the key people involved from each charity, and we're actually working with people at senior levels. So we have a lot of shared knowledge and a lot of shared learned experience going back over many, many years. And I think you'll see our next slide will actually show the cumulative efforts that we've all put into cleft care in terms of surgery, nearly 2 million surgeries over the past 30 years, many comprehensive interventions. And I think the important thing for us is it's truly international, over 125 countries, and we've trained as well as treated patients. So I think it's a very rich mix of experience that we brought to the table. And just before I pass on to my colleague, I'll just go through the actual initiation process, how we actually came to be, which was, as Hugh said, in 2017 in Chennai, and there was an NGO day. It was the first day I was co-chairing, and there was a question in the audience, and there was an idea that because we all know there is some bad practice happening in countries where there isn't a protocol, there isn't the resources, there isn't communication, there was an idea to actually develop some international standards that we could all draw from, and we would actually help and encourage others to follow those practices. And very delighted. It has been a journey. We've really found working together across these organizations has been a huge strength, and we think we've been a great team, and we think we've answered the challenge that was put to us in Chennai to actually come up with some meaningful, ethical, safe standards for cleft care globally. So I think Ruben is next. I think Ruben's on mute.
Sorry, I was on mute. Yes,
Okay.
thank you, Gareth. And before I begin, just a huge gratitude to Nan from Transforming, Dr. Nan Hudson from Transforming Faces, who's with us today and play a key role on just with great interventions and knowledge to support the process throughout. So as we sought to create a team that could take on the important charge suggested in Chennai, we looked at bringing not only different organizations, but individuals with diverse backgrounds from such organizations with the ability to go into their constituencies or teams to better reflect the ideas, values, and the diversity of thought and practice of the organizations represented. And our teams met monthly or bi-monthly, really since 2017 until very recently. We went on to determine team priorities, and looking at the great deal of diversity of cleft care, there was a lot of debate on those priorities and what a group like ours could do, from creating a quality consortium to certify, oversee activities, to ultimately what we believe was a more inclusive priority, which led to focus on not on matters of oversight and technique or timing of care, but on a broader resource for delivering ethical, safe, accessible, and patient-centered care. And as we did this, we sought to be very inclusive and encouraging, avoiding mandatory and prescriptive approaches. So there's some preliminary efforts that have been proposed. We're going to spend the vast majority of our time today on that. So I'll move on and for now, but it's all centered on ethical, safe, and accessible care to patients. And we realized that as we put these efforts forward, we wanted to go through greater evaluation, scrutiny, and solicit feedback, understanding that we could nourish the product from the diversity of opinions and experiences from many different groups engaged in cleft care. And we are here as part of that continuation of those efforts to disseminate what we have put forward together, and to continue to ask for insight and engagement and an application of some of these practices. So ultimately, when it comes to our preliminary efforts, what we were looking for, we were looking really for to follow some overarching principles. So before going into specifics, we focus on things that we felt we really cared about the most. So things such as safety, comprehensive nature of treatment, capacity building, competencies needed to deliver care, focus on patients, and a real understanding of the patient's rights. And there were 8 major areas that were identified by the group, which were divided into 2 sections, in minimum core standards and best practices, realizing that different teams or different groups might have different resources at their disposal, but having a baseline and pushing forward for the ideal scenario. And those areas include surgical safety, quality control, patient and education and selection, patient follow-up, comprehensive care, partnerships, the concept of partnerships with whoever you're working with, and training for sustainability and local capacity building. And our ultimate target was to create globally recognized treatment program standards as a tool that would serve a bit of a compass to many organizations, teams, institutions looking to offer services and expand access, understanding that such entities might span across different parts of the world and work under very different circumstances with different infrastructure, human resources, financial resources, regulatory requirements, leading to a great deal of variability in their approach today. And their patients also coming from different settings, having to overcome endless barriers to access that care, but ultimately looking to have the international program standards offer a pathway towards very safe, comprehensive, and sustainable care.
During the gathering process, for us, it was very important to leverage our collective years of experience, as Gareth had mentioned. So what we wanted to do was to focus internal and external, our internal members and partners and the external ones, to not reinvent the wheel and to look really, truly, and deeply at what was important for each organization that had led them to this point. So at first, we wanted to talk about mission organizations until we realized it was actually anybody who's involved in cleft care at any level, and to have a focus on long-term sustainability and partnership. We made a very good point not to focus on timing and interventions, and to stick to the principles of what was important for us, what's ethical, what's safe, what's accessible, and what's patient-centered care.
Yeah, so a huge part of this process was actually debating. We were connecting monthly, often more than monthly. And if you can advance through and just put all of those up, that would be perfect. And throughout those discussions, we really considered many different viewpoints. As discussed by other panelists, we really wanted this to be something that was inclusive and aspirational. There are many different circumstances in cleft care and presentation of patients, in what's realistic or even mandated locally by guidelines. So we needed to have something that would be something that everyone could utilize. So we discussed, for example, whether it should be an aspirational document or required, encouraging or mandatory, whether these should be goals or rules. And we really ended up very much on the left side of that balance. It was important that we focused on the wording too. We spent a lot of time, nuancing over different words and making sure that the language wasn't mandatory or prescriptive, but took into account the significant variability of the local situation, and allowed everyone to be able to still utilize and grow from this document. Next slide.
And again, we try to stress as much as possible on the surgical safety and minimum core versus the best practices that are needed and are essential for us to maintain safe care delivery. So looking at the timeouts, basically has been kind of a crucial thing. The pre-op surgical assessment of the patients, the anesthesia situation, the post-operative care, and certainly this has been shown to enhance the safety and the quality of care of the patients. What are the protocols for emergency care preparedness? And are the teams basically providing the care for the patient inside the operating room and on the floor, capable and able and staffed and well-trained in managing any potential emergency that might arise? And to that effect, basically, we've looked into the situations of earthquake, fires, acts of terrorism, things that might interfere with the delivery of care, cardiac arrest, respiratory arrest, malignant hyperthermias, every single potential complication that you can think of. The team basically delivering the care has to be kind of well-trained for and equipped to be able to handle these things. And the patient surgical safety checklists that have been described by Dr. Atul Adwandi and have been modified since then by many of our groups basically are crucial. And we have shown actually that it not only saves lives, but also saves a lot of money that is involved with the potential complication that might happen if these patient safety checklists are not pursued. The best practices is to really ensure the safety of the patient in all aspects of their medical care and with thorough vetting for the patient preoperatively, intraoperatively, and postoperatively as well. Quality control also has been shown to be a crucial thing for us to concentrate on. Is one reviewing the outcomes, how is it being analyzed, are the complications being documented, and how are they minimized, and what kind of a process do you have to have a complete medical record, whether electronic medical record or a paper medical record, so that the visiting team as well as the local team on site have the ability to retrieve these messages. Many a time the teams come in, they operate, they leave, and the local team, if that exists, basically it's left stranded, not knowing what has been delivered to what patient and what kind of quality care and what kind of complication might not have happened and things like that. In the best practice setup, basically a routine assessment of the outcomes and the complications is crucial. I know that many of the founding organizations with the World Cleft Coalition have our own internal assessment of quality control. So when the teams come back, basically what we call it M&M, morbidity and mortality assessment, whereby you look at the outcomes, you look at the results, you discuss all these outcomes with your team, whether basically it's a visiting team or the team on site, and you say what did we do well and what didn't we do well and how can we improve on that. and the protocols that basically for the delivery of this kind of good care and assessment should be in place as well. From a patient safety point of view, basically, again, after decades of being involved with this kind of work, there is nothing like a well-educated patient and family. They need to be involved, they need to partner with you, and you need to make sure basically that they're all informed throughout the whole process from A to Z on what kind of care is the patient receiving. So this is important before even getting the consent form. Just having the patient sign on a piece of paper does not really give the patient the proper care, and the family basically the full knowledge that what their family member is undergoing. From a best practice point of view, we believe that the patients need to have clear information about all the healthcare professionals delivering the care. So whether this is basically through on-site information or through the kind of loyalty and the predictability that they have with the visiting team and the on-site team, but having people who are very well trained in their specific field and delivering the right care that they should be delivering is crucial. Not having somebody not performing cleft care in their own setting and coming down to a site and trying to experiment on the patients, and as a result, the patient basically end up paying the price. From a patient selection point of view, following the standards basically to minimize the patient's risk is also very crucial. Does the patient have any underlying comorbidities? Have they have any situation that might interfere with them undergoing general anesthesia? Is there any record of them undergoing surgery before with potential complications or complications that might have happened? All this thing is very crucial. Is there any other comorbidity like cardiac abnormality that needs a cardiac evaluation and any other neurosurgical or neurological that as well that needs the pre-op clearance? From a best practice point of view, there has to be screening system in place. In our own situation, as many of the founding members have, patients are pre-screened a month before, and then they're pre-screened again before the surgery is performed. Anyone with any underlying comorbidities basically are evaluated, thoroughly vetted before the decision is made whether or not that they can undergo the appropriate surgical procedure. Next. In that venue as well, there has to be multiple specialties involved in this decision making for whether or not the patient can undergo this kind of a procedure. And after the procedure is done, what kind of a system do you have in place for the follow-up? Do they have the written instructions? Have you educated the family and the patient on what to do post-operatively? Do they have a contact person? Are they supposed to come back a week, 2 weeks, 1 month, 6 months, and so on and so forth? Do they have all these instructions readily available? Due to the COVID pandemic, we have expanded also into the utilization of telehealth that is now allowing us to follow up on all our patients using the WhatsApp and the video applications, and that really has enhanced the quality of post-operative care in our field. The best practice core is basically not to have only the surgeons, but the other specialists involved with the patient the care delivery also involved in that regard as well. As far as the comprehensive cleft care is concerned, many of us know that we continue to struggle, and we've done several assessments right now. And with this is a paper that we just recently published on what are the challenges facing many of the on-site team, and it continues to be the lack of availability of comprehensive cleft care. And that means basically is, for you to have a proper comprehensive cleft care team, you need anesthesiologists, group dentistry, nursing, orthodontics, pediatrics, psychosocial support, speech and language pathology, as well as the surgical team with the overall coordination provided. The best practice is certainly you need to bring in the other specialties, including audiology, pediatrics, restorative dentistry, genetics, ENT, psychology, and social worker. And the partnership on site is very crucial. You cannot be looked upon as we call the gringo group coming in and running out. You need to develop strategic relationships with your on-site partners. And that is very crucial through the development of strategic affiliations and memorandum of understanding with the NGOs, the hospitals, and your local partners. And definitely as a best practice, ongoing exchange with the local healthcare provider is very crucial to enhance also their quality of care delivery and their training as well. As again into the same in the same venue, the enhancement of the training through empowerment and sustainability is the thing that we all need to be looking for, whether the minimum core or in the best practice, so that we can develop a multi-specialty and multidisciplinary team that can deliver quality care on site, whether the visiting team is there or not. And this is what we call the diagonal model for care.
So the next steps that we saw as a group were, as we've mentioned from the beginning, one of the most important pieces of this project is the continual input and feedback. We've continually discussed this as being essentially a living document, something that is always changing and adaptable. Certainly COVID has, as we've talked about already, has presented some new challenges to our world. And so, you know, a lot of these ideas and discussions we had were pre-COVID, and just even the recent publications that Dr. Usama had even mentioned and more, those publications are really kind of shaping our views of how perhaps some of these World Cleft initiatives might be changing as well. So we do want to always continue to stress that the value of that continual input and feedback. For that reason, we've developed a website, and this website is listed here, and we would sincerely ask that each of you would take time and log in and get familiar with the website. There's a place where you can also add comments and suggestions and have an alignment with these standards. We're looking for partners to align with these standards. We've discussed this idea of, do we have people sign up for alignment, or do we, you know, we really want this to be a team driven idea, basically, where people feel that there's an alignment, they agree with the ideas that are presented. And if they don't, that they're sharing those ideas on the World Cleft Coalition website. And then we're using those to adapt and modify this living document to make it the very best that it can be for our community. With that, we do want to thank you all. We're so honored to be a part of this group. It's incredible, the number of people here, and to have this opportunity. This, as mentioned right from the beginning, has also been evidence of what can happen when groups come together from across the world to create a unified vision and idea for cleft care. So with that, we open that up to the group for questions.
Thank you, Dr. Perry, and thank you to all of our panelists. Fantastic. So you'll see in the chat, there's been a couple links posted, but especially if you haven't previously viewed the World Cleft Coalition website or the summary of their program, that is the heart, I think, of what, after all that process of consensus and discussion and debate and language wording, is where the group ended up and what was published. And so now, as always, and the group's done, can you imagine all these presenters, and we still have a good amount of time to discuss. Huge kudos to there. I'm gonna get my reaction button here and just give a little, that's amazing. Wow, well-oiled machine, really strong presenters. What do you think? How do these kinds of ideas of these standards and the process that was journeyed, what does it mean for your context of delivering comprehensive cleft care, or working towards comprehensive cleft care? What are your questions for individual members of the group? And let's go from there. So let's start thinking through how this can work. How can we make use of this resource, or what would you want to have more clarity on, or even some next steps on? So I think I see it. One of the first questions that came up, Dr. Debbie Sell. Do you want me to read it, Dr. Debbie, or would you like to ask it yourself?
I can ask it. Yes, it's a brilliant piece of work, and great to see all the organisations working together in this way. I just worry that the list of professionals in that core, in the recommended section, would be viewed by people as slightly less important. And I understand from Usama's comment why you felt you had to do that, but is there a sort of sublime message about those particular areas? And particularly for me, hearing and ENT and psychology is just social work so important as well. It's just so yeah.
No, certainly I agree with you, Debbie. We really kind of struggled on where to include this section, but we had to factor in really the realities on the ground when you get there. Many of the teams are not really equipped. Many of the hospitals don't have audiology booth or well-trained audiologists to perform this. So we said if we want to put it in the minimum practice, and knowing that probably this might not be available in 60–70% of the thing, then people will say, well, we're defeating our thing and we're not really meeting up even to the minimum practice guideline. So we had to factor that in. But bringing in ENT and audiologists and checking on the ears and making sure that the patients are really receiving the right care is very crucial. We just got back from a mission actually in Lebanon, and the PDENT at the university was training with the group along with many of the residents because we're the largest group right now doing this work over there. And she said, shall we do the tubes? I said, that's fine as long as you're going to follow up these patients and follow them up for free, not charging them as they come in to see you. And what happened actually in Mexico, I don't know the famous story, a well-intentioned group from California flies in a small plane. They put tubes for around 200 patients over there who needed the tubes. And then they leave. And then 6 months later to a year later, the Mexican ENT started seeing all these kids coming in with mastoiditis because they were jumping into these pools and ponds and swimming and without any proper precautions or training or education, and ended up actually putting the tubes and did more harm than actually just letting them go and as the situation would develop. So you always have to gauge in, are we doing more harm than good? And in the same situation, what are all the factors on the ground? So this is among many of the things that we struggled with, and we decided then to include them in the best practice section.
Thank you, Usama. I see Ruben first, and then go ahead, Ruben. And then Erin.
Debbie's point is critical, and Debbie, I think I would like to reassure you that the intent was not to have the unintended consequence of lessening the importance of those specialties. It was actually quite the opposite. If you begin and you don't have the specialties, you actually have to strive and work towards that, having those specialties, if you really want to have comprehensive care. So if that's something that you read the document that is not necessarily properly highlighted, it is worth of noting. But we did begin with the basic things that you might need and then look to expand understanding the diversity of practices and resources. But the intent was to push everyone towards that comprehensive nature. And there are endless stories about how people's lives have been impacted by the professionals in these areas. So.
Thanks, Ruben. And I think that is a key grounding point that both Ruben and Usama have mentioned for these standards. This is not built in a vacuum where any resource is available, everyone's trained. You have active audiology departments or speech language pathology departments pumping out graduates. So I think that is an important element of this is looking at the context of low and middle country context, which is really the central organizing principle of these webinars as well. Erin, please.
I was going to make a very similar point to Ruben, which is this is crucially important. And if we look at the success of cleft children, if there's long-term hearing loss, obviously their outcomes are going to be significantly poorer. And making sure that we're considering audiology and psychology is essential. I think it is one of the things that in all contexts has historically been overlooked, whether it's in missions and an inability to do longer term follow-up on these patients potentially, or in some local settings, it's been something that hasn't been prioritized enough in the development of the team. At Smile Train, it's something that we've begun piloting at a number of our centers and are hoping to scale globally in the coming years, which we're really excited about. But it is one of those things that is not currently available on missions or in local centers, but something we definitely want to draw attention to the need for everyone to work towards building it in.
Thank you, Erin.
Can I add
so I
one
see
thing?
Serena and then Jamie.
Jamie, go ahead. I'll go after Jamie.
I was just going to mention real quick too, I think going back to the idea of minimum versus best practice, our idea of minimum was really that if we don't have these things, we have risks. Best practice was if we have these things, we have benefits, we have advantages. So keeping that in mind, it was kind of like a risk versus optimal. And that really drove a lot of our discussions. But Dr. Sell, you're spot on that this was probably one of the biggest topics that we spent the greatest time talking about. So it doesn't surprise me that this was the first to pop on your mind, as it was on ours as well. And we debated and went back and forth a lot on this. So it's a great question. Serena.
Thank you, Dr.
I
Serena.
love what Dr. Perry said, Jamie. That was beautifully said, because I think Dr. Sell, that was the point that I wanted to bring up too. I'm a pediatric dentist, so I'm in the best practice. And this, like Jamie said, was a huge point on discussion. And I think if you remember back to the ACPA guidelines when they changed in 2010 and scaled down who they needed to be certified as a team versus who could be available, a lot of specialties got worried, myself in particular, as well as pediatric dentistry. So for this on us, like Jamie pointed out, who do we need without this will be a risk, and then who can we have as scalable? So we wanted all the teams to feel like they could be a comprehensive team with the ability to scale up with the additional specialties, but not to lose out on starting with where they are, and to honor that.
Thank you, Serena.
I'd like to address a couple of things as well. One Dr. Summerlad basically has brought up is about speech and following clefts. And again, this is something as well that we have been kind of struggling with for quite a while. In our own teams, we have developed on-site speech pathology experienced groups, as well as we have our own speech pathology assessment forms that will follow up on these on the patients whom we're delivering care. But Brian, you're 100% right. I mean, this is quite an issue of, palates are being repaired, but how do you follow up on these patients to assess basically the quality of their speech and the outcomes as well? What we're hoping as well from our own EMR is that through the speech assessment postoperatively, you can figure out that Dr. A has better outcome of speech than Dr. B, just from into our internal own review, and then accordingly try to figure out how can we modify one's technique to try to improve these kind of outcomes. This is the kind of assessment that has to be done in-house, and I would love to see if maybe collectively us as a World Cleft Coalition, in collaboration with many of our friends here, we can come up with some kind of an expanded policy to address some of these issues.
Thank you, Usama. Brian, you have one rejoinder, please unmute yourself, feel free.
Just a comment on this issue of speech assessment. I've just had some correspondence this morning with Pam Sheeran from Smile Train, and she was sending me a paper from Iran. There are some papers from Iran generated by Fatima Derekshandi, who's a speech pathologist, looking honestly at their outcomes. And their initial paper showed 66% moderate or severe hypernasality. If only we could have more of that. And then they published a follow-up with where it's come down to, I think, 44%. If only we could have that sort of honesty around the world, and people not feeling embarrassed or ashamed about their outcomes. I think in the UK, that has been achieved to some extent with the sort of centralization of cleft centers and the publishing of outcomes. But worldwide, it's really, that information is very, very sparse. And my question was, how many of you around in this this very august body, how many of you have looked at, really honestly assessed speech outcomes in the places where you're working?
Thanks, Brian. And I'm be happy for anyone to weigh in on this also. It does connect in though to some of the chat that's been happening here. I mean, I think before we even get to the idea of honesty, I think back to Usama's example about, a well-meaning group in, putting in tubes, but then potentially having no way of following up to see. So before we even get to the honest part, the idea of how we track patients, how do we follow up? How do we even know whether, how successful a surgery has been or any kind of treatment has been? presupposes that we have some way of organized and teammates who are involved in actually tracking and following up and in documenting what's been happening. So there's been quite a bit of comment about how we follow up on these things so we actually even know, either to the group or to anybody else. What's the intersection between having a good EMR or medical records or some sort of system for following up and the ability to implement these kinds of standards?
I mean, you need to have well-trained speech pathologists with expertise in endoscopy. You need to have the pediatric endoscopy kit and video stroboscopy evaluation assessment all available. You need to have all the equipment available for them as well to document all the stuff. You need to have pediatric and well-trained ENTs and other craniofacial, cleft surgeons who know how to assess these outcomes from a VPI point of view and document this, and then it keeps rolling up. So and this is where basically we believe that it's kind of incremental steps in what all of us are trying to do from a empowerment and sustainability point of view, and from the workshop point of view to try to enhance the quality of training for people to try to address many of these issues. I think maybe, and this is something nice that Brian had brought up, if we as a World Cleft Coalition, we can maybe start addressing one issue at a time that is kind of challenging for us, and try to see if we can come out as well with a multi-NGO kind of proposal or solution for this thing. But this is certainly, it cannot be done overnight, but certainly it needs to be aspired.
Thanks, Usama. Erin, jump in. Yeah, please jump in, Erin.
I'm so glad that you're continuing to communicate with Pam, Dr. Summerland, and bring up these important issues. We have been working really hard because it is, as you said, Usama, a very complex system that needs to be in place with well-trained people with the right equipment to be able to do these evaluations, and then surgeons that can optimize outcomes. And while it's challenging, it's something we've really been successfully moving the needle on at a number of our centers. We've been supporting through our grants program the purchase of this equipment, the training of professionals on these teams. It's not happening everywhere yet, but it's certainly something that we are moving forward. We've also worked very intensively to train up our speech therapists around the world and ensure that there is a sense of team care happening on our teams, where they are both having their speech outcomes evaluated and working closely with the surgeons, and evaluating outcomes over a multi-year period of time to really work together to determine whether there's therapy needed, whether there's additional surgery needed, and what follow-up is in the best interest of the patient, as well as evaluating outcomes that may on an ongoing basis not be optimal, so we can intervene there from a quality perspective. So it's certainly a complex issue, but it's one I think I agree we all need to prioritize, and it's something that over the past few years we've really been prioritizing. There's lots of work to be done. And Debbie just made a wonderful point. It's the perceptual speech outcome is really important too. It's not just through the endoscopy. So yeah, it's that linking, ensuring that the speech therapist is at the table and has a voice, and that discussion of all the patients is taking place.
Thanks.
Yeah, go ahead.
No, that's great. So much to dig into here. Dr. Fell, Matt, please, you've studied the document a little bit. Do you want to ask your question? You want me to read it for you?
Sorry, I pressed return, so it doesn't really make much sense, my question, but I was just reading through, and it starts talking about the phase 2 of the document of getting feedback. I just wondered if there was a plan for that, of how the group are going to do that.
Thank you. And that's obviously, there's some of that that's happening here already. Gareth, would you like to address that? Oh, you're still on mute, Gareth. This is still 2020.
Still on mute, Gareth.
Okay, yeah, that's a really key point. I think everyone recognizes that knowledge is worthless unless it's actually applied, and the process of getting people to sign up to the document is a process of engaging and involving. So we have produced what we set out to produce, and we are now trying to receive feedback, and what we're doing today is something we're really looking forward to hearing from you. We also published a paper in Cleft Palate Craniofacial Journal, again, in the process of having that published. The question was, what happens next? So we have a document on the table. We would actually like people to review and feed back to us, and yeah, it's a living document. There is a process on our website which is available on the chat, where you add your comments, add your suggestions, and I think there's a feeling that we would like to have as many organizations, NGOs, aligning themselves to the overall aim of implementing this as their sort of gold standard document within their work. So yeah, I mean, that's not a very specific answer to what you asked, but I think in a sense it's something that we've been asking ourselves about. Where do we go from here? Do we listen to feedback from everyone, get more people around the table, and have a living working document? Is there an end point? How do we know when we've achieved what we wanted to achieve? Are there other areas of work? It could be, we've been talking about priorities right now. Are there other areas such as hearing development, whatever, that we as a group, collaborative group, could actually work on together as an offshoot of this? For me, as I suppose my main role within this process has been facilitating the group and actually getting all the heads around the same table. And we've had very frank but very rich conversations about the way forward, and having 6 different organizations that haven't regularly worked together in the past really being very positive in their exchanges has been really heartening and enlightening. So the spirit of this is what's in it for me. So that's, I'll
Thanks,
finish
Gareth.
there. Yeah.
Very good. I think that is pushing, and I think Ruben's point in the chat also, just about how it's time to change the way we engage with each other into something more constructive and supportive. As the group submitted their proposal, I mean, one of the pieces that they were saying was both, innovative, was both the standards that was agreed upon in a consensus kind of way, these minimum standards, but also the process of working together for organizations that, as Gareth delicately put it, don't necessarily have a great long history of working together in this kind of structured way. And I think that probably is something that really stands out for many people on this call who have been funded probably by one of the organizations, or at least one of the COCP organizations along the way. I don't know if anyone wants to comment a little bit more about this idea of how, even if each of our organizations have different emphases and different histories and different focuses, there was an idea of finding something that we all could live with and work with. What was that process like? Who's going to put their neck out?
Let me just.
Ruben, please, you started us off. Go ahead.
Actually, I saw Erin. Go ahead, Erin.
I mean, I think it went well. I think it was really important that we all recognize the different ways we're working, and then where there is both opportunity to potentially come together. But I think, to be honest, I think the thing that helped us the most was always taking it back to the patient, always keeping the patient at the center of what we're doing, and really working to determine what is in their best interests. I think regularly reflecting as well on the fact that the state of cleft care in the world is so different in so many places. So whether we're all different groups and we're all delivering care in different ways, just looking at how complex the situation is, regardless of who's at the table, really helped, I think, guide us in putting together something. So I think it was not contentious at all, and overall just incredibly productive. We also really kept those international colleagues, the people that are on the front lines of delivering this care, and often in very low resource settings, at the front of our minds, who don't have always the benefit of what we may have in Canada or the US or the UK, and really thinking about how to empower them and support them. I'll turn it back over to you, Ruben. Thanks for letting me go first.
Thanks, Erin. It's just an agreement. So what could potentially be really contentious actually was a very constructive process of ongoing learning. So once you start getting rid of your assumptions on what people do or don't do, or groups do or don't do. And you open yourself to actually trying to understand and to other opinions. And you put yourself in a position of humility where if someone's doing something that's really good and you can learn from that, you take that and say, oh, this is something I might be able to bring back to the organization. And all focusing on the patient, as Erin is mentioning, and the people that are closer to the patients, there is a real opportunity and hope that the process in itself can be constructive and the results extremely positive. So going back to Dr. Sommerlad's point, I remember, I mean, I've gone to a fraction of the conferences that he's gone to over the years, and I remember shouting matches between people in conference because we've held on to our mantras. This is the way to do it. And but on the other hand, over the years, I've seen a real shift, probably more passive and organic than sort of active, from that point to trying to understand and try to comprehend, just because people are looking for solutions for our patients. Because even though we've done so much work, we're not even close to addressing all the needs of patients. So the way, it's good to see the publication that's coming from Iran, I believe is that you mentioned. Mm-hmm. I know that we're about to share another from Nicaragua, and it's hard to kind of put yourself out there with things that you don't really feel that great about. But the hope is that we learn from each other rather than to use that knowledge to go against each other. Listen, ultimately focusing on the patient and the providers that are closer to them, it's the reason we're here. So I do see hope for the future, and I COCP is another example. We're all here for the, so I'll stop there, but the processing itself has value.
Very good. No, it's good to hear from Smile Train and Operation Smile on this. Jamie, please, from the ACPA.
Yeah, I was just going to mention just briefly I think the short answer is we all focused on the main thing, which was improving patient care. And as Ruben mentioned, that the pinnacle or the center of all of that has to be coming in with the humble perspective that it's not about us, it's about the patients. And I think when we take the focus off of us as providers, to Dr. Sommerlad's point, we can begin to say, how are the patients doing? Not how are we doing, but how are the patients actually doing? And that has to be the focus for peer-reviewed publications, for initiatives, for everything that we do, because ultimately it's never about us. The legacy is not us. It's about our patients and the lives that we transform. So, it was humbling, as I love that word Ruben mentioned, because sitting on these calls, you realize that there's not a person on that call and not a person on this call that doesn't have that common value and core that drives everything that we do. So if we keep focused on that, it was a productive and fruitful conversation.
Thank you for peeling back the onion a little bit, letting the rest of us kind of peer inside. These are really helpful reflections. So we've talked a little bit about collaboration and teamwork among NGOs. I think back to some of the points that we heard throughout how to implement these standards, there is an assumption that people have an ability and the skills to actually work together as a team, even among the people who are on the ground, to be able to reflect. I mean, I was thinking even in Usama's point about the critical importance of having a meeting to self-assess, what went well, what didn't go well, how can we learn from that? Tell us a little bit more from someone on the group, how do we equip teams on the ground to be actually able to work effectively as a team to get the information they need to do that self-reflection, so that potentially it leads to research or anything else, but to actually, so we know that what's actually been happening. And then that can't just be one person, whether it's a local leader who's always lived in that context, or someone who's coming from somewhere else. What's the interplay between team-based skills and that team leadership and the ability to implement these standards?
This question is addressed to whom, Hugh?
I'm opening to the panel. Do you want to jump in? Your point led me to it, but I think it's been underlying some of these things. Go ahead, Usama.
No, I mean, again, as everybody, I just build up on everything that had been said by Jamie, Erin, and Ruben. Basically, it has to be a collective effort. There has to be somebody who takes an interest in bringing the local group together and trying to form a comprehensive team. it has to be incremental steps. I think that basically that all of us collaborating together is very good, but I certainly, as Suraj said, how do you join the group? You can either email us or log onto the website, the worldcleftcoalition.org, and just send us an email that goes to Serena, so that we can hook up with you guys. The hope is that we can increase the scope and the collaboration with other organizations, and to try, because collectively, between the 6 organizations, the founding members, we have, almost like 200 years worth of experience in the field, that we can hopefully guide other people as well in the process, so it is less painful, and on how to address these issues. As I always say, the commonality between us as human beings and as NGOs is more than the division that we self-create or the blinders that we put. So I'm hoping that this World Cleft Coalition will continue to grow and have more groups participating and trying to address many of these kind of tricky questions. But the key point basically, even at the small local level, it has to be a comprehensive team. And I think in the book that Brian and I and many others are working on publishing in a year and a half, we've asked Gareth and Jordan Swanson to address this issue, is how do you develop cleft centers in low and middle income countries with the minimal resources available? Because I know this is kind of a very challenging question that I'm hoping that Jordan Swanson and Gareth can really address and be it kind of a roadmap for people to help out.
Thank you, Usama. And thanks for bringing that up again, because I mean, that for this circle, but also for the World Cleft Coalition, that is a unique insight that they bring, is being really rooted in the experience of people who don't have every resource potentially available, every university program, every technology. So the idea of putting all of these in context of how do you make do, how do you ensure patients having a great experience and safely moving forward, while also recognizing that the sky's not the limit in terms of all the resources that can be available. We are at the end of our time. This has really flown by. I knew there'd be some good interaction and engagement. I know lots of people probably have other comments and questions that have been brewing that they're just sort of thinking through how to articulate. I think this idea of this being an ongoing journey, that this is one landing point but is not finished in terms of collaboration and figuring out how to implement comprehensive cleft care in these kinds of environments is a real encouragement to us all. So you'll see along the chat several times have been posted the link to the World Cleft Coalition. There is, within the COCP, there's also the ability to post on Slack. And Niti, I'm not sure if you want to share that last slide just as we finish up. So between the two places, there's lots of places to be able to engage and think through how these work. Some of you, this will be your real introduction. You've seen this perhaps before, but haven't really engaged with these standards. Now I'd encourage you to do so. And if you do have thoughts or comments or things, as was mentioned, that maybe are not articulated the way it works in your context, this is the right time. And I think you've heard from Gareth on down, everyone's saying they would like more feedback and more interaction. And this is obviously one step with this huge turnout we had this morning and or this afternoon or this evening on this environment. So anyway, thank you very much to our presenters for the whole journey and for everyone joining us today. We are planning to move forward with a strong endorsement of all COCP NGOs, saying we'd like to continue this process with this incredible growth we've seen in 2020 through the pandemic. We know that the pandemic is going to be influencing our work in one way or the other throughout 2021. So we'll continue. If you have a topic, if you have a presenter you'd like to recommend, please do so. We'd love to hear from you at info@cleftcircle.org. For those of you who are celebrating holidays coming up, we wish you all the very best. And as we all look forward to 2021, just acknowledging again, many of us are in really difficult circumstances because of this pandemic. And we acknowledge that. We thank you for taking out time. We're thinking of you and really hoping for better things as we move into the new year. So thank you, everybody.